What if one of the most important organs in your body could be quietly failing without you even knowing? In this episode, we are joined by Padma Shri Dr. Arvinder Soin, one of India's most celebrated liver transplant surgeons, Group Chairman and Chief Surgeon at the Medanta Liver Transplant Institute, and a pioneer who helped establish liver transplantation as a successful specialty in India. With over 5,000 liver transplants to his credit and decades of experience saving lives, he has transformed the landscape of liver care in the country. From why fatty liver has become a silent epidemic to the future of GLP-1 medications, liver regeneration, and the simple habits that can protect your health. This is a conversation filled with insights everyone should know.
Can someone look completely healthy from the outside and still have a fatty liver?
Of course.
I work out, I don't drink, I don't eat outside food. But is it possible that I can have a fatty liver? So, I want to talk about GLP-1. There's a lot of buzz about GLP-1. A lot of people are talking about GLP-1. What is it?
Would you believe it that 1 out of 8 American adults are on GLP-1 drugs?
What? Has been glamorized by Bollywood people, young founders.
Yeah.
Right? In last 2-3 years.
Yeah. We all know many Bollywood celebrities who have it.
Yeah.
We shall not name them.
Okay.
Yeah.
On liver, average waiting list is 8 to 12 months, and 90% of the liver patients can't manage to live that long.
So before we get into everything we are going to discuss today, I would love to start at the beginning. For someone who is hearing you for the first time, how would you introduce yourself? Who is Dr. Arvinder Soin?
Thanks, Saurabh, for having me on the podcast. I think that the way that I would describe myself is that I'm a scientist. I'm an Indian, and I'm a humanist who has learnt and practiced the art of healing through medicine and surgery for a very long time. Why do I say I'm a scientist? Because, you see, I was indoctrinated into pretty early on in my life, and I understood that doctors are healers, and I had amazing examples within my family, both my paternal and maternal grandfathers. I mean, my Nana and my Dada both were doctors. And later on, when I started to be a doctor and then became a doctor and then took my oath at the time of my graduation, when I became a doctor, I understood that the Hippocrates oath, which all doctors take when they become doctors, basically tells us to use all the knowledge that we have to heal every person that we can in the most compassionate, scientific, and ethical fashion, without causing them any harm. In fact, although it's not a part of the Hippocrates oath, primum non nocere.
What does it mean?
Primum non nocere.
Okay.
It basically means first do no harm.
First do no harm. Okay.
It basically says that when you're starting out to be a doctor and you start healing and treating people, it's your responsibility to make sure that your patient or the person that you're treating should not end up being worse than what he started with. So you're not caused any harm. So first you have to make sure you don't cause any harm, and then you have to make sure you cause him good, or you treat him well in a way that his malady is, resolved, or his disease is cured. And so this is a long explanation for the scientist part of me.
What age you became a doctor?
I became a doctor at 23, which is when most of the doctors become doctors.
Okay.
So in 1986, so I was born in 1963. So I say scientist because that's one method. The scientific method is one method of
through which all the treatments, medicines, drugs, surgical procedures have passed. And it's been concluded that a given surgical procedure or a given medicine treats the patient with a particular problem well compared to if you don't give that medicine and doesn't cause harm.
Yeah.
So we have learnt the medical science over a number of years, over 40 years of my practice. And that is why I'm a scientist. I'm using that knowledge and the scientific method to treat and to heal. The reason that I say Indian, I mean, it's obvious I'm an Indian, but the reason I say I'm an Indian is because I'm obsessed with making the best of treatments, the best innovation. I want to make them happen in India.
In India.
I've always been like that, and I will continue to be like that. When I trained in the UK and I learned my liver transplantation in UK. And when I was there, I got my UK passport. There was no visa problem. There was no job problem. I got an amazing job at Cambridge University, something that people would die for. But I got an opportunity to return to India and start liver transplantation in India. It did not exist then. In 1990,
You were the first one, right? Who introduced liver transplant in
So
India.
in 1997-98, I got this opportunity to return to India and start liver transplantation, and I jumped at it. And when I left that job in Cambridge University, everyone around me, my friends and my colleagues, seniors, juniors, everybody thought that I was completely mad to leave that opportunity and jump into Indian healthcare, where obviously liver transplantation did not exist. And in terms of tertiary care in 1997-98, things are now very different. But then we were not up to speed with a lot of the complex work that medicine or tertiary or quaternary medicine entails. So we were not up to speed in India.
Okay.
And it was seen by my colleagues and friends as a retrogressive step.
Okay.
That I should be actually, I had an amazing career ahead of me in the UK, and then I decided to return to India. But I have no regrets at all. It's been
What do you think about it now?
It's been an absolutely amazing journey, and I love being here. And whenever I publish papers, some of my fellows and my students would say that, let's write this as the first series from India. I said, no. You don't have to write India as a suffix to any scientific contribution. It should be at global level. You don't have to mention it India.
Absolutely right, yeah.
Let's write that this is the first time advanced cancer patients can be treated with radiotherapy and liver transplants, rather than write it's from India.
Yeah.
Because we don't want to be crying for attention. Just because we are from a third world country or supposedly from a third world country. So I always put our country first and at level with any other developed country in the world, as far as at least medicine is concerned and surgery is concerned, right? I mean, you can't be blind to a lot of things that we are probably lagging behind in.
Correct.
But at least in my field of practice, I can say with confidence that in clinical care, we can give as good clinical care in India as exists anywhere else in the world.
Okay.
And I have been a great proponent of pushing innovation in my field in surgery in India. And many of the firsts that I and my team have been able to accomplish, I don't want to get into that, but I'm just kind of explaining the Indian part of my description. Many of the firsts have been world firsts.
Right.
And it's a matter of pride that, we are able to do that in India for the first time in the world.
Correct.
So that's the long explanation for why I'm a scientist, an Indian and a humanist.
So you started your journey with Apollo.
Yes. Dr. Pratap Reddy, who's the founder of Apollo, he's, of course, a legend in healthcare. And he happened to be in England in 1997. Because he had just set up his Delhi hospital at that time. And he and his team invited about 30 doctors from all over UK in different fields and different specialties, because they wanted some of us to return to India and to populate his hospital and practice the advanced latest in tertiary care medicine and quaternary care medicine. And so he met me and he said, Dr. Soin, I know that you're doing good work in Cambridge, but we have set up absolutely top-class multi-specialty
Facility,
hospital in Delhi,
Delhi.
and would you like to come and start liver transplants in India, because they don't happen in India. And I went home to my wife, and I had been offered a lecturer's job in the Department of Transplant Surgery at Cambridge University at that time already. And my wife was doing her PhD also at Cambridge.
Okay.
And we discussed this for about 5 minutes, and we both decided we are going back.
In just 5 minutes?
Yes.
So quick.
It didn't take us long at all. So, and of course, we took 7-8 months to wind up, and then we came back. And then on the 6th night of November 1998, I did India's first successful liver transplant in Apollo Hospital.
Wow. So, how does someone become a liver transplant surgeon?
So first you have to become a doctor,
Yeah.
and then you have to become a surgeon. So when you become a doctor, you do MBBS. When you become a surgeon, you do MS, that's Master of Surgery.
Yeah.
And then you do a specialization, which is usually GI or hepatobiliary surgery.
And
GI is gastrointestinal,
Okay,
and hepatobiliary surgery. Hepato
yeah.
means liver.
Yeah.
And then you become a liver transplant surgeon.
So, was this always the plan?
So, very interesting question. Surgery was always a plan.
Yeah.
Because I somehow had that idea from very young days, maybe when I was 10 or 12 years old, that physicians, due respects to all physicians give medicines, and they have to keep giving medicines for a long time for people to feel better. Whereas surgeons just go in, fix whatever's wrong,
Yeah.
remove whatever's diseased, and the problem is solved. So I was more like a here and now kind of doer, more like a instant gratification monkey.
It is more fun also.
So I have been always inclined to surgery. And then I was at AIMS, and I was in the Department of Gastrointestinal Surgery, doing my specialization after general surgery. And I found that things were they were in the nascent stage in liver surgery. Things were not very well developed. And there was no transplantation, but I didn't think of transplant at that time. I just thought that it would be nice to do advanced liver surgery, and I was also fascinated by cancer surgery.
Okay.
So then I went to UK, and I thought that I'd learn advanced hepatobiliary surgery. But then it turned out that all the centers that do advanced hepatobiliary surgery actually are transplant centers. And then I got into Queen Elizabeth Hospital, Birmingham, which is one of the very renowned hepatobiliary and liver transplant centers.
Okay.
Yes. And then after a year there, then I went to Cambridge University, which is also very renowned for hepatobiliary and transplant surgery. And then I did my usual FRCS qualification in general surgery. Then I did FRCS in transplant surgery. Then I was offered a job after my training as a lecturer. That's the first level entry to faculty in any university department. So I did that. And then after about nearly 7 years in the UK, then I told you the story of how we decided to come back. And then we came back.
Okay, so I'm going to start with, you have been practicing medicine from last 3 decades. Am I right?
Over
3 decades.
So I became a doctor in 1986.
1986, yeah.
That's nearly 4 decades.
4 decades. Yeah. So if you compare the patients walking into your hospital today from the ones you saw 25 or 30 years back, what has changed the most?
So if we look at my specialty, because along the way, I have practiced gastrointestinal surgery. Then I branched into hepatobiliary surgery and transplantation, specifically liver transplants, kidney transplants. I've also done some pancreas and intestinal transplants, but not a lot of those. those don't happen in large numbers in India.
You have done kidney transplant also?
Yes,
Okay.
yes. Because I was trained in a multi-organ transplant center in the UK.
Okay.
In Cambridge and Birmingham, we used to do both kinds of, all kinds of transplants: liver, kidney, pancreas, intestine. So we used to do all of those. So I trained in that. So I came back and did that. I have to tell you an interesting thing about kidney transplantation. So when I was in Apollo, we did some liver transplants, and of course, that was the first program in the country that supported liver transplantation. But there wasn't enough patients having liver transplants. So then I
Okay.
thought that I have to keep myself professionally busy. So then I said, let's concentrate on kidney transplants.
Kidney transplant, okay.
And that was again a problem. Why was it a problem? Because the whole chain of referral from a kidney specialist physician who's called a nephrologist to a kidney transplant surgeon was pre-established.
Okay.
They were not waiting for Dr. Soin to come and do
Do
stuff.
the transplant, yeah.
They already had it going. And this is not obviously, I'm not blaming anybody, any hospital or any doctor, but the system was set. And they didn't need me.
Okay.
So then I decided that I had to do something where they will need me. So then I went to US again in 1999 to Baltimore, to Maryland University and to Johns Hopkins Hospital. And I learned how to do laparoscopic removal of the kidney.
Okay.
So that time, kidney donors had open surgery to remove the kidney, and the relatives donated one kidney for their, person who, their
Okay, so only
family
relatives can donate.
So yeah, so we can talk about that separately, but how this works in kidney transplantation is that you have two kidneys, and if both are normal, then donating one kidney doesn't do you any harm. You can live happily with the other kidney.
Okay.
So kidney transplantation, again, 80% plus of the kidney transplants in India are done through living donor kidney transplantation, which means a family member donates one kidney for the kidney failure patient. So this living donor kidney transplantation was well established. The system was set. There were nephrologists, there were surgeons. They didn't need me, but they were doing open surgery for the donor. So then I went and learned laparoscopic surgery for the donor, which means the donor didn't have to have a big cut across the side of the tummy, and they could have it with three little holes and a small cut about 2 inches to remove the 2.5 inches to remove the kidney at the bottom where it's not seen. And then I came back in 1999 after about just under a month of training, and I did the country's first successful laparoscopic kidney removal.
Wow. And that is also in Apollo.
That was also in Apollo.
Okay.
And for me, it was both. It was bringing innovation to India, but also survival.
Survival, yeah.
Because I had to do enough work.
That's more important.
Yeah. It was okay to do like 6 transplants in 1 year
Yeah.
and feature in the papers saying this happened, that happened. But it didn't satisfy me professionally. Okay. So then I started that, and then, sure, after initial skepticism, this laparoscopic thing picked up. And then I started getting a lot of referrals, so I became very busy with kidney transplants.
Okay.
And liver transplants was carrying on alongside.
Okay.
And then I had, in 3 years in Apollo, I had done hundreds of kidney transplants and a lot of, about 22 liver transplants only. And some other surgeries, of course.
How many transplants you have done till
Now about 5,000 something.
5,000 liver transplant till
Yeah.
now. Wow.
5,000 plus, yeah.
And what about kidney transplant?
So I did about 1,500 and then I stopped
Why?
because I became very busy with liver transplants.
transplant,
So for the last 10 years, I have not been doing kidney transplants proactively, but sometimes patients need liver and kidney transplant in the same person.
Okay.
Because they have liver failure and they have kidney failure.
Kidney failure.
I do both. I do those. I do the simultaneous liver and kidney transplant wherever it's needed in a patient. I will do both of those together in one patient. There I will transplant the liver and the kidney. I will do it.
Okay.
But in patients who need kidney transplants for kidney failure, I don't do it anymore because we are just a very busy liver transplant and hepatobiliary system.
And how much time it takes for a liver transplant?
Liver transplant takes about 7 to 8 hours. So liver transplant is not one operation, it's 2 operations generally, because 90% of the liver transplants in India are done through living donors. Or let's say 85% or so. Yeah, 85% of liver transplants in India are done with living donor transplants, which means that a family member of the patient who's suffering from liver failure or liver cancer will donate half the liver.
Okay.
Okay. And that half liver is donated to the patient. The patient's bad liver comes out completely. And I will explain on this model. So this is what a liver looks like, approximately this size.
Yeah.
It sits here in the right upper abdomen.
Okay.
And this is a plain looking liver, which is like a normal liver. And when the liver is bad, it just goes nodular.
Okay.
It's scarred. And what we do is, when the liver is bad and it's scarred, it's called chronic liver disease or cirrhosis.
Cirrhosis. Okay.
We can talk about it later.
Yeah, we can talk about it later.
And the point is that bad liver is removed from the patient, and the donor's usually right half is given to the patient. The left half that remains in the donor and the right half that goes to the patient.
Okay.
Both will grow back to normal size within 2.5 months.
Wow, interesting. You said something interesting. You said 75% you are doing is living donors.
85% of liver transplants in India are living donor transplants.
Why a deceased person can't donate his liver?
I'll explain that to you. So I'll just finish the part about how long it takes.
Yeah.
So there are 2 operations in a living donor liver transplant. There's a donor operation and there's a patient's operation. They both take about 6 to 7 hours and 7 to 8 hours.
Okay.
And then there is anesthesia before and reversal afterwards. So total duration from when a patient goes into OT and comes out of OT is maybe 8 to 10 hours.
Okay.
For both donor and maybe 1 hour less for the donor and same for the patient. So there are 2 operations happening to make one living donor liver transplant happen. Donor operation and a patient.
Patient operation.
Yeah.
Oh.
Anyway, so now you're asking me about why do people who die not donate organs? Right?
Yeah.
So that's again a very kind of
But
it's a
that
question
can happen, right?
It's a question. Yeah. I'm just telling it to you. So that's a question that requires a detailed answer again. Sorry.
Okay.
A dead person can donate organs for transplantation, like liver, kidney, heart, intestine, pancreas, etc. only if they die a brain death.
Only if they die
A brain death. Let me
death.
explain.
Okay.
Only 1% of deaths are brain deaths. 99% are deaths where people will die at home or on the road or in the hospital, where the heart stops first
Okay.
and everything goes, right?
So when you say brain death,
Brain death is that happens to people who are in the ICU,
okay.
whose brain stops completely working and it's irreversibly damaged, and there are medical criteria to show that the brain has died. But these people are on ventilators, so the rest of the organs can function for a day or two.
Okay.
They are perfused kind of, they're on ventilator and they're on some intravenous fluids. So fluids and ventilator and support can keep the other organs of the body going for a day or two.
Okay.
Such people become organ donors. Not anybody who dies.
That's a very small number then.
Yeah, that's 1% of all deaths. But in terms of eye donation, you can actually retrieve the corneas
Corneas, yeah.
and transplant them. You can, within 4 to 6 hours of death, they will work.
Okay.
So most people who die can donate eyes, but only 1% of the people in their brain death can donate organs.
Okay.
Not the remaining people. Now, what happens is that there is a little nuance and a problem with that. So when somebody dies a brain death, that means they are in ICU and their brain is gone, but the other organs are You know, when
Working.
you go and see the monitor, there is a heart rate, there is a blood pressure, and it's very difficult to tell the family that, look, your near and dear, your loved one is dead
Yeah.
by brain death. They'll say, but I can see his heart is going, he's got a pulse, I can see his chest moving. So how is that happening?
Correct.
So that is the state of brain death. And there's a lot of awareness that needs to be spread to society to understand that brain death is equal to death. Nobody will ever wake up from a brain death. It's not like...
What are the chances of that person to be alive?
Zero. If they satisfy criteria, which are medical criteria, which are tested. So if somebody is thought to be brain dead in an ICU, the doctors will do what is called a brain death testing.
Okay.
And those criteria are etched in stone. Once the person who is supposedly brain dead by those criteria, he or she will never wake up. It's not like coma. From coma, people can wake up.
People can wake up, yeah.
Because coma is upper brain death.
Okay.
Or let's say brain dysfunction or damage. So there are two types of death: circulatory death, which is 99%,
Okay.
and brain death, which is 1%. Circulatory death can happen, that means the heart stops, the pulse stops. That will happen anywhere.
Anywhere, yeah.
And brain death will only happen in a ICU, usually a
ICU.
neuro ICU, which means they are on the ventilator, they are on ICU support, and the brain stops functioning completely and irreversibly, which means that it is damaged by a stroke or a hemorrhage or a head injury in a road traffic accident or something like
Correct.
that, right? So those kind of people are the only ones who are able to donate solid organs like heart, lungs, kidney, liver, intestine, pancreas, so on. And so the problem with donation is that, first of all, not everybody who dies can donate.
Yeah.
Secondly, the perception of death is very different. If somebody's heart stops, breathing stops, and pulse stops, you and I, everybody know, whether you're a doctor or not, you know the person is dead.
Yeah.
But if the person is in ICU and the ventilator is pushing his breathing, so the chest is going up and down, and the monitor shows a pulse and a BP because artificially it's kept going, even when the brain is dead, it's very difficult for family to come to terms with the fact that the person is gone.
No more.
And they don't want to think about that.
Yeah, right.
They don't want
Nobody
to come,
wants to think
They don't
about
want
that.
to come to terms.
Correct.
They'd much rather not believe it. They'll say, no, he's okay.
Yeah.
Or she's okay. So that is the problem. So that awareness needs to be spread, that once doctors who think that somebody is brain dead, if they run those criteria, which are given by law, if the person satisfies those criteria, then that person is never waking up. So brain death is equal to death has to be understood by society. The government and the non-government institutions have to, and the organizations have to promote this concept, because it's grief time for the family, but 9 lives can be saved and another 30 can be positively influenced by a single person donating after their brain death. So that's a cause in itself which we have to push in India. Unfortunately, we are lagging behind, and that is the answer to your question as to why there are less donors after death compared to living donors.
Living donors.
अब देखिए, ऐसा है कि किसी को लिवर फेलियर है, किडनी फेलियर है, और आधा लिवर देने से या एक किडनी देने से जान बच सकती है. सो दिस
बट ये चेंज आ रहा है, लोग दे रहे, डोनेट कर रहे हैं अभी.
नहीं, आई एम सेइंग कि लिविंग डोनेशन तो ऑब्वियसली
लिविंग डोनेशन हो रहा है. आई एम टॉकिंग अबाउट द डेड.
माय ब्रदर इज डाइंग फ्रॉम लिवर फेलियर, आई विल डोनेट हाफ माय लिवर.
करेक्ट.
Or if my sister is needing a kidney transplant, I donate 1 kidney. That's easy.
But what about the person who is no more? Are they donating organs? Are their family donating
brain
organs?
Death, the donation after brain death rates are rising very slowly. Saurabh, I'm so sad about this. This is one of the unfinished tasks that I have in my head.
What's the reason behind it?
So let me first tell you how drastically low the donation rates are in India. So Spain has a donation rate of 58 per million. US has a donation rate of around 48 per million. We have a donation rate of 0.7 per million.
What?
0.7. About 100th of or 80th of Spain. So I think the most important thing is that there has to be awareness spread about what brain death is, that person cannot wake up after brain death, then donor, or that you can save so many lives after brain death by donation. And organs are never bought and sold, never. There is no organ in this country, and hopefully I'm speaking for every human being, every country. There's never a sale and a purchase of an organ, not legally anyway. Okay?
Correct.
Everything is by voluntary donation. Living donation is voluntary, and even donation after death is voluntary.
That is also voluntary. Yeah.
Right? So there is some misconception in people's minds that these organs, will be sold to rich people. There are others who believe that if my child or my brother or my father donates the organs, then the next time he's born, he will be without those organs. So there is this myth. So there is this disbelief, which I told you about earlier, that if somebody is brain dead, I don't want to, if it's my loved one, I don't want to accept it. So I'm in denial. So all of those reasons can be offset by awareness campaigns. You have to make people aware. So now, what are we doing? So the government is actually now including the concepts of organ donation in school curricula, so that children in school and then later college understand what donation is. Because you see, how do you make a societal change? You have to change the children.
Correct.
And the younger generation.
Right.
So that's been done. It's been included in the driver's license in many of the states, where it says that I wish to be an organ donor.
Okay.
In case I die of brain death or whatever.
Okay.
So that there's this option. I mean, this option has been there in the developed countries, in UK, US forever. Like when I was there 30 years ago, I ticked I want to be an organ donor on my driving license then. But now it's coming into India for the last 5 years. It's been different states are adopting.
So I mean, government is taking initiatives.
Government is taking initiative. It's a large country. It's a very unwieldy population in terms of size, and any initiative takes a lot of doing.
A lot of efforts, a lot of time, and in country like India, it is going to take time because. But the main question is, can you see the change? Is it happening?
We are seeing the change.
Yeah.
So until 15 years ago or 18 years ago, they didn't used to be a very organized system for organ donation. But now there is an organization called NATO. National Organ and Tissue Transplantation Organization.
Okay.
And then there is a ROTO, regional, and there is a SOTO, that's state.
Okay.
So there are
national, regional, and state.
These are subdivisions of NATO, which function like you can register your patient from a hospital that's, say that he or she is in the waiting list because they need a transplant, liver, kidney, whatever. And similarly from all over the country. And then whenever an organ becomes available in an ICU in any hospital, they notify NATO or SOTO.
Okay.
And they coordinate for it to happen.
And how hard it is to find the organ? Is it difficult?
An average waiting list for a kidney transplant patient could be 3 to 5 years.
What? 3 to 5 years?
They are on dialysis, so they can somehow manage sometimes to be waiting that long. For liver, average waiting list is 8 to 12 months, and 90% of the liver patients can't manage to live that long. So they will either die on waiting lists, or they will get a...
So why is it like that? Why...
They will get a loved one to donate for live donor transplant.
Why it has such a long waiting list? What's the reason?
There are few organs and there are many takers.
Okay.
And so that's why a lot of them will convert to living donor transplant. There will be somebody in the family who will get motivated to donate half a liver for them after waiting for 3, 4, 5 months when they become sicker. So with liver patients, you need urgent transplant by and large.
Yeah.
You can't wait for 1 year, 2 years, that kind of thing.
But liver is the only organ which can regenerate.
So that's pretty amazing about the liver. So,
exactly.
Yeah. So, again, so now let's say there is consider donor.
Yeah.
There is a donor who donates half his liver for his sister's transplant. So that person has donated the right side. So in terms of volume, about 60-65% is gone. So
Okay.
35-40% remains.
Remains, yeah.
The remaining will again grow back to, so he started with, let's say, 1,000 grams of liver, and he loses 630 and he's left with 370.
30%, 40%.
Yeah, just under 40%. Then he will become again 1,000 grams, his liver will again become 1,000 grams of liver within 2 to 3 months.
2 to 3 months.
Yes.
Wow.
So that's regeneration. That's amazing. And liver has another amazing quality, and that is reserve.
Reserve.
Reserve means that 60% of your liver could be damaged and you would not feel a thing.
That's my second question.
Yeah.
Why we don't feel anything? अगर brain में कुछ होता है, we can feel it.
हाँ.
Kidney में कुछ होता है, we can feel it. But why we can't feel anything?
Liver is an amazing organ in another way कि जब liver का damage शुरू होता है तो उसके कोई symptoms, कोई ऐसे manifestations नहीं होती हैं. आपको समझ नहीं आता है कि अब मेरा liver damage हो रहा है. वो liver is a silent sufferer.
Okay.
That means अगर liver damage चल रहा है तो कुछ पता नहीं चलता है. 50%, 60% डैमेज तक तो बिल्कुल ही कुछ पता नहीं चलता है. 50% के बाद कभी कभी थोड़ा सा टायर्ड, देयर आर नॉन स्पेसिफिक सिम्टम्स विच यू कैन नॉट रियली पिन डाउन टू लिवर डैमेज, लाइक थोड़ा सा टायर्डनेस होता है, थोड़ा सा वीकनेस होता है, थोड़ा अनीमिया हो जाता है, हीमोग्लोबिन की कमी हो जाती है. So these are the early things that happen with liver disease. Once it goes to 65-70% damage, then you get the symptoms of liver disease, like you can have swelling in your leg, swelling in your tummy, you can have blood in your vomit, blood in the stool, and you can have the effects of liver failure on the brain, which means थोड़ी drowsiness आ सकती है, थोड़ी confusion आ सकती है. So these things start to happen after 65-70% liver is damaged. So because you don't even realize when your first 50% of the damage has occurred, it's important to keep testing regularly.
Okay.
Otherwise, you will never find out.
So what is the first step? What is the first step? कहाँ से चालू होता है? 50% 60% आप बोल रहे हो कि liver damage हो जाता है और लोगों को मालूम भी नहीं पड़ता है. So what's happening inside the liver? Since we have got the model here, can you actually show us?
Okay.
Yeah. What does a healthy liver look like versus one that is not healthy?
Okay.
Yeah.
Good question. So a healthy liver is approximately this size.
Okay.
And it's smooth, just like this liver is. And it sits here in the upper right part of the abdomen, partly under the rib cage.
Okay.
Right? That's where it's located. And the liver is quite an amazing organ. It performs more than 500 functions.
Okay.
And when the liver gets damaged, and I'll tell you the 4 main reasons, and the most important reason is fatty liver.
Fatty liver, yeah.
Fatty liver itself is not a reason, but it's what happens to the liver because of many causes, like uncontrolled diabetes, like being overweight, like having bad lipids or dyslipidemia, bad cholesterol, having poor lifestyle, like too much
Alcohol.
junk food, alcohol. We're leaving alcohol aside right now.
Okay.
Too much junk food, fried food, processed food. And all of those things. And then there is some genetic tendency also for fatty liver.
For fatty liver.
So these are the 4 or 5 causes of fatty liver. Then there is alcohol, which is a whole new disease.
Okay.
Alcohol-related fatty liver is also a thing. So non-alcoholic fatty liver, alcohol-related fatty liver, hepatitis C, hepatitis B, these are the 4 causes why liver goes bad. So when the liver goes bad, it initially goes from, let's say we talk of fatty liver, that means there is fat in the liver, which is more than 5% of the total volume of the liver. When it's less than 5%, you don't call it fatty liver. When it's more than 5%, then it becomes fatty liver.
But it has become very common. Fatty liver has become very common now.
Nearly 40 to 45% of Indians, adults will have fatty liver. Yes, it's very common. That means I'm saying that in a room, nearly half the people will have it. It's that
What's
common.
the reason? Because पहले हम old लोगों में सुनते थे जिनमें fatty liver होता था. आजकल young में सुन रहे हैं. क्या reason क्या? What's the reason?
So, our livers are suffering because of our lifestyle, unfortunately.
Okay.
And you have to, it's not just the liver that is suffering. The whole metabolic system, the metabolic health of a person is suffering because of a poor lifestyle. And that is the most important reason, right?
When you say lifestyle, can you explain us more? Let's go deep dive into it.
Okay, so pardon this acronym, but I often say that all of us, with the lifestyle we lead or the lifestyle we have, are making our health go to piss. Piss, as in PISS. P for processed food. I for inflammation drivers. S for sedentary habit. And S for sleep debt. That's what we are doing to ourselves. So these are the primary reasons why our metabolic health is bad, why our livers are fatty now more than ever. It's a rising problem, a rising epidemic in most countries. Worldwide, the incidence of fatty liver is between 30 and 50%. In India, it's about 40-45% of the adult population.
So what can we do about it? How can we stop it?
So, reverse all of these things. So that means that in terms of lifestyle, you have to have obviously proper nutrition and diet. And I'm not a dietitian, I'm not going to detail everything in the diet, but suffice it to say that you should have no processed and ultra processed food. Ultra processed food is simply food that you will find in a store, from the one that you buy from a store rather than get from a field. Like buns, cakes, cheese,
all the packed products,
stored meats, packed products. All of these are the processed and ultra processed foods, and they also have fructose. All of that, like all the sodas, all the fizzy drinks, they all have fructose, right? And they're also processed. So they have some preservatives. So all of that drives inflammation, insulin resistance. Insulin resistance is the early, we call it precursor, which means it's the first warning sign of diabetes.
We have heard this term, insulin resistance, in the last 2 years, 3 years. People were not talking about this term 5 years back. What is it? What causes it?
Yeah. So I'm just saying why people have fatty livers, and I'll tell you what insulin resistance. So they have fatty livers because of taking too much processed food. And the other is that they are, possibly consuming sweet things, fried food, and which is basically the definition of junk food. So to sort that out, you have to take high protein diet, whole grain carbs, and nuts and walnuts and olive oil, and of course green leafy vegetables are amazing. Every kind of green leafy vegetable is good. Avocado is good. Cauliflower, broccoli, all of these are very good, right? So you have to do all that. Alcohol as a part of a lifestyle problem is a big no-no, right? And you should get good sleep and you should exercise. So this is the way to avoid insulin resistance and fatty liver both, because they both go hand in hand. Now, insulin resistance क्या है? Insulin resistance है कि हमारी बॉडी में ग्लूकोज जो शुगर होती है, जो हम कंज्यूम करते हैं या कुछ भी और कंज्यूम करते हैं, उससे शुगर बनती है, इंसुलिन उसको डाइजेस्ट करता है और स्टोर करता है, राइट? So insulin resistance means कि जब insulin is trying to act to store the glucose or metabolize the glucose, the cells which do it are not responding to the insulin. So that's called insulin resistance. And उसकी advanced stage 5 साल 10-20 साल बाद फिर डायबिटीज बनता है. तो इंसुलिन रेजिस्टेंस को हमें पिक करना बहुत जरूरी है. और लिवर की हेल्थ और फैटी लिवर ना होना उसी के ऊपर निर्भर करता है.
So help me connect the dots. if someone gains a little belly fat,
Yeah.
then develop fatty liver, then blood cholesterol, blood sugar, then high blood pressure. So are these separate disease, or are they all part of the same process?
Very, very, very interesting question. And the answer you've given yourself, they are actually part of the same process.
Okay.
That is metabolic ill health. Metabolic ill health क्या होता है? Metabolism क्या है? Whatever we consume, the food, is metabolized, means it's broken down to consumable forms in the liver.
Correct.
Okay? Whether it is storage and breakdown and storage of glucose or glycogen, whether it is protein synthesis, whether it is fat synthesis and fat storage, the cholesterol, different forms of cholesterol are made in the liver.
Yeah.
So liver metabolizes food. And metabolic ill health comes from the fact that metabolism is not effective or is not perfect. And insulin resistance is the central part of that.
Okay.
Which means that insulin ki action restrict ho rahi hai. So if 2 units of insulin are needed for you when you don't have insulin resistance, you will need 4 when you do have insulin resistance. So if you test fasting insulin, वो बढ़ा हुआ मिलेगा इंसुलिन रेजिस्टेंस में.
समझ गए.
और ये जो नए so I'm still answering the question how liver is at the center of metabolic ill health. फिर क्या होता है? इंसुलिन रेजिस्टेंस पहले लिवर में आती है, फिर मसल में आती है, फिर फैट डिपोजिशन होता है. फैट में इंसुलिन रेजिस्टेंस और होती है फैट डिपोजिशन होने से, और फैट डिपोजिशन होता है तो फिर जब इनिशियल सबक्यूटेनियस फैट आता है, स्किन के नीचे आता है, लेग्स आर्म्स के नीचे आता है, पर उसके बाद फिर विसरल फैट जमा होना शुरू हो जाता है. विसरल फैट होता है जो इंटरनल ऑर्गन्स के आसपास फैट होता है. नो दैट इज इन्फ्लेमेटरी फैट, व्हिच मींस दैट इज एक्टिवली secreting inflammatory, we call them cytokines. They are chemical substances which cause inflammation, like IL-6, like TNF alpha, like CRP. All of these can be tested in the lab. They are secreted by fat cells in the visceral area. Subcutaneous fat जो होता है, dummy fat होता है, वो इतना एक्टिव नहीं होता है. जो विसरल फैट है वो बहुत एक्टिव होता है.
और ये रिस्की भी होता है.
और ये रिस्की होता है. ये डायरेक्टली रिलेटेड है हार्ट डिजीज से, स्ट्रोक के रिस्क से, डायबिटीज से, मोटापा जो ठीक नहीं हो रहा है उससे, फैटी लिवर से. ये डायरेक्टली सब चीज़ों से रिलेटेड है. ये आप दिस इज द वे लिवर डिसफंक्शन, फैटी लिवर, मेटाबॉलिक dysfunction is all related and eventually results in diabetes and risk of strokes and heart attacks. It's all completely related.
So it's a cycle, na?
So liver is at the center of metabolic health, and metabolic health is at the core of chronic diseases. All the chronic diseases.
So can someone look completely healthy from the outside and still have a fatty liver?
Of course. Liver could be great.
I work out, I don't drink, I don't eat outside food. But is it possible that I can have a fatty liver?
So it is possible, although less likely.
Okay.
Because if you're exercising, then you're using body's own armamentarium to fight fatty liver and to fight insulin resistance. One way of not having insulin resistance or having good insulin sensitivity, that's the opposite of insulin resistance, is to have good muscle and good exercise routine, you know. So because क्या होता है कि with exercise and maintenance of muscle, your insulin sensitivity is maintained or even restored अगर insulin resistance भी आना शुरू होता है तो. So exercise is a very good way of maintaining good metabolic health.
You are seeing a lot of patients. क्या एज ग्रुप के लोग आप सबसे ज़्यादा देख रहे हो अभी?
Fatty liver के?
Fatty liver के या liver disease के?
So liver disease unfortunately stretches across all age groups. If we talk about liver diseases, I unfortunately have, well, they're doing well, but unfortunate that they had it. I've treated people who are or persons who are from 3 months of age to 80 years of age.
Okay.
So it is seen across all age groups, not specifically fatty liver, but liver disease in general. Yeah, and fatty liver is obviously most commonly seen between 20 and
Correct.
60. You know,
Yeah.
and so you see, you will be. There are 3 simple ways that you should monitor your metabolic health.
Okay.
One is waist circumference. Simple.
Waist?
Waist circumference.
Circumference.
It should be 30. For Indian men, it should be less than 36 inches or
Okay.
90 centimeters. And for Indian women, it should be 32 or less. Waist circumference. If
Okay.
it's zyada hoga, then they have extra fat, they have more visceral fat, and again the whole chain which I told you about with visceral fat, more insulin resistance, more inflammation, all of that will happen, right? So that's a very good estimate.
Okay.
The
For
other is
men's 36 and for women's 32.
32. I mean, let's not get into figures.
Yeah.
But what happens is that now, for example, then the other good estimate is triglycerides and HDL.
Okay.
उनका जो ratio होता है, you know, that is important.
Okay.
So if it is less than 2, it's very good.
Okay.
2 to 4 is like obviously borderline, but 4 plus is dangerous and causes, you know, it's a risk for heart attack and strokes. So these are the parameters that you have to look at when you want to understand your metabolic health. Of course, there are other parameters up. You can measure HbA1c, you can measure insulin levels, you can measure something called HOMA-IR. There are many methods of doing this, right?
So you said something about cirrhosis. So
Yeah.
is it related to cirrhosis and fibrosis, the fatty liver?
Yeah. So initially there is fat in the liver, then there is inflammation, which is called hepatitis. Then there is fibrosis, which
Fibrosis.
means scarring has started.
Okay. Scarring.
Scarring has started. That's what F1, first level, F2, F3, F4.
Okay.
And then when advanced scarring is there, when the liver is 50% or more replaced with scars only because of damage, then it's called cirrhosis.
Cirrhosis.
Yeah.
And cirrhosis,
And cirrhosis
is
will
the...
slowly go into liver failure, the protein manufacture in the liver will stop, the processing of bilirubin, which happens normally in you and me, our bilirubin levels are less than 1, will start rising because the processing will not happen. The detoxification will not happen, so the toxic products will reach the brain and they'll cause brain symptoms. So this is what happens when the liver stops functioning.
And cirrhosis is the final stage.
Cirrhosis is the final stage.
Okay.
And all cirrhosis patients do not need transplants, but
Okay.
there are 3 stages of cirrhosis, A, B and C. The ones in late B stage or C stage will definitely need a
Need
transplant.
liver transplant.
Yeah.
Okay.
And earlier ones can be managed with medicines.
What are the percentage?
But the whole idea is to not let people go to a cirrhotic stage. Idea is to prevent liver disease. So prevention is clear. You prevent fatty liver by, I told you, all the stuff that you should not be doing. I mean, you control your diabetes, control your lipids, control your weight, and so on. And then control your alcohol. And hepatitis B has a vaccination, so everybody should have a vaccination against hepatitis B. Everybody.
Okay.
Hepatitis C itself is not, there's no vaccine, but it can be prevented by preventing, transmission through blood and through sexual intercourse. So awareness is important. You know,
So-
body fluids spread that like AIDS. So hepatitis B and C spread like AIDS.
Okay.
basically, through body fluids and through sexual intercourse.
Okay.
So I'm saying all the awareness is needed. Hepatitis B, there is vaccination. So you prevent liver disease. I think that 90% of liver disease is preventable. 90%.
90%.
Yes.
But as you said, कि 50% तक तो लोगों को मालूम ही नहीं पड़ता है liver में होता है.
हाँ.
And that's the main reason I think.
That is the
Cirrhosis भी हो जाता है तब तक भी नहीं मालूम पड़ता है, right? Okay. So I want to talk about GLP-1. There's a lot of buzz about GLP-1. A lot of people are talking about GLP-1. What is it? So the biggest health trend over the last couple of years has probably been GLP-1, Ozempic, Mounjaro. They've become part of everyday conversation. Why? What's the reason behind it?
So these are pretty revolutionary drugs.
Okay.
ये ड्रग्स वो हैं कि आपकी जो इंसुलिन रेजिस्टेंस है और जो डायबिटीज़ है और वेट गेन है और फैटी लिवर है, ये तो प्राइमरीली ये ड्रग्स कंट्रोल कर सकते हैं जी। और इनके सेकेंडरी इफेक्ट्स और भी जगह देखे रहे हैं। ब्रेन की कॉग्निशन इम्प्रूव करना, लगता है कि इवन एजिंग को स्लो डाउन करना, ये इसके भी नॉट साइड, आई मीन दीज आर extra beneficial effects that have been noted in series. But let's concentrate on the main effects. The main effects are basically these drugs are given for weight loss, diabetes, and fatty liver. These are the three reasons these are given. Now, these are called GLP-1 drugs because of glucagon-like peptide 1 RA receptor agonists. Okay? So, इसका मेन एक्शन ये होता है कि इंसुलिन रेजिस्टेंस को कम करता है, इंसुलिन सेंसिटिविटी को इंक्रीज करते हैं, इंसुलिन रिलीज को इंक्रीज करते हैं, ग्लूकागॉन जो कि एक ऑपोजिट हार्मोन है उसको सप्रेस करते हैं, एंड जो स्टमक में फूड स्टेज फॉर अ लॉन्गर टाइम व्हेन यू टेकिंग GLP-1, सो ऑब्वियसली उसकी अब्जॉर्प्शन कम होती है, और जितनी होती है वो एफिशिएंट होती है, तो फिर वेट गेन कम होता है, ठीक है, और वेट लॉस होना शुरू हो जाता है। और जो हमारी बॉडी में दो हार्मोन्स हैं, लेप्टिन एंड ग्रेलिन, दे आर सैटिस्फैक्टरी एंड हंगर हार्मोन्स, या तो उनका जो इफेक्ट है वो नेगेट हो जाता है।
कंट्रोल्स हंगर आल्सो, राइट?
हाँ, दैट्स राइट। तो GLP-1 देने से जो हंगर हार्मोन को सप्रेशन नहीं होता है, लेकिन हंगर हार्मोन का जो इफेक्ट है वो negate हो जाता है,
okay,
by giving GLP-1. So hunger goes down, the food stays in longer, the insulin sensitivity rises, insulin is released. So all of these effects result in lowering of sugars, lowering of weight, lowering of fatty liver, and control of diabetes.
But do they worry you in any way?
So they worry me because a lot of people, would you believe it that 1 out of 8 American adults are on GLP-1 drugs?
What?
Yes.
It's very expensive also, right?
How much does that make it? 1 out of 8 is like about 12-13% people.
Yeah, 12-13% people
are on GLP-1 drugs in the US, according to a recent study.
And what about India?
Much lower, but
Much lower, yeah.
a lot of people are entering this, whole field, this zone for lifestyle, in lieu of lifestyle. So what I just said, you should exercise, you should eat healthy, and all that. In lieu of that, people just take this as a shortcut. But the problem with that is, if you are taking a GLP-1 drug, whether it is Ozempic or tirzepatide, which is Mounjaro,
Mounjaro,
you will bounce back to the same weight within 3 to 6 months if you're not.
Once you stop
if you're not actually doing lifestyle changes along.
Oh.
So I never prescribe
GLP-1
drugs to somebody who's not motivated to change their lifestyle. Only if you change your lifestyle. So we normally have a 3 to 6 week trial of lifestyle change, and if they've demonstrated lifestyle change and they have lost some weight and they've lost some liver fat and their tests have become slightly better, then we aid the process by giving GLP-1 drugs.
Okay. It has been
It should only be
glamorized,
medically taken under supervision of a doctor for a specific reason for which they have been researched and scientifically validated.
It has been glamorized by Bollywood people, young founders.
Yeah.
Right? In last 2-3 years.
Yeah. We all know many Bollywood celebrities who have it.
Yeah.
We shall not name them.
Okay.
Yeah.
So you spoke about longevity. I have heard that you are doing something interesting work in
Yes.
it.
So Saurabh, I have worked at the critical end of the spectrum of disease, specifically liver disease, for the last nearly 40 years. And I have done thousands of liver transplants and have had the good fortune of saving all of these people. But imagine how many people don't get to liver transplantation, how many people actually die of liver disease. I'm sad to say that possibly 100 times that number would have died, not directly seen by me, but generally in the hospitals that I work and my colleagues, because they could not access liver transplant, right? So I now have become very passionate for working in the opposite end of the spectrum also. Of course, I continue to do my liver transplants because people need them as life-saving operations, and I'm very passionate about the surgery. But I'm now passionately working on the other side as well, where I want to prevent people from getting there. So I want to work on preventive and predictive and personalized medicine with a completely medical, scientific lens, because that's what I am. I'm a scientist and I'm a doctor. And we've already started this online, and we will have a physical center, one in NCR, then we'll have another one. We'll have countrywide centers over the next few years. So first center launches in 3 or 4 months.
Wow.
And this venture is called BeyondAge Innovations.
BeyondAge. Wow.
Yeah, BeyondAge Innovations. So BeyondAge has an on-ground team of longevity physicians, and it has a top layer of specialists like metabolic health specialists, sleep neurologists, cancer prevention guys, liver health, cardiac health, cardiologists, preventive cardiologists, endocrinologists, and aesthetic specialists. So we have 10, 11 top, country's top specialists in their fields who are now putting their efforts into the preventive side. So you're kind of preventing what we normally treat.
Right, yeah.
So that is this venture. And the passion comes from the fact that I think that 80% of chronic diseases and 60% of cancers are preventable. So obviously, if you prevent all of these things, then you're going to extend healthy lifespan.
Exactly.
People live healthier and longer.
So should we be thinking less about living longer and more about
Healthy living.
healthier,
Yes.
right? Healthier for long.
Very good, because I completely agree with that. So the whole aim is to optimize health span,
Correct.
which means how long you live healthy. That's the important part.
That's the important part.
I'm not
right?
interested in living 100 years if the last 20 years I'm in the hospital.
80 years में आप अगर hospital में 20 साल निकाल रहे हो, then
20
what's the
साल,
point?
Last के 20 years का कोई point नहीं है.
Correct.
लेकिन अगर if I am at 100, what normal people are at 65 or 70,
Yeah.
and I live 98 good years, I want to be 100. Why not?
Correct.
You see? So that is the whole point. At BeyondAge, we want 60 to feel a 40 or a 80 to feel a 60.
16.
That's the whole idea.
So what's
And
that?
this is not gimmickry. This is science.
This is science.
Yeah.
It can happen.
For sure. For sure. We have protocols that we have basically got from the world scientific literature,
Okay.
and all of our specialists that are involved in this venture, their knowledge. And the only other thing that I am very keen to say here is that we are doing this with a science base and making sure that people achieve positive health outcomes. It's not about testing.
Yeah.
Any number of people do any number of tests. What do you do with those tests?
Correct.
So you have to be told scientifically what to do to improve your parameters. If your HbA1c or triglyceride HDL ratio is bad, then you have to have a roadmap of what to do.
Exactly.
And
Totally agree with you, yeah.
And then people have to follow you up to see that you've done it and that you've improved your parameters. Your life is enhanced and your health span is optimized only when there are measurable outcomes. So we are focusing on those.
I really want to know what separates the people who stay healthy into their 70s and 80s from those whose health start declining much earlier.
Genes 20%.
Okay.
What you do with your genes and your life 80%. Is that a good answer? Okay, now let me explain. What you do with your life is how you live your life.
Correct.
Right? And I'm sorry, but it's not rocket science, but it's something that people don't do. And that is exercise, sleep, nutrition, emotional balance, and inner calm.
What do you mean by emotional balance?
Emotional balance and inner calm is so important. If you're trying to give up sweets, you're addicted to sweets. You're trying to give up sweets. What is going to come in the way of your changing that habit? Your inner being, your mental status, your emotional status. In your brain, you know that it's good for you not to have them.
Yeah.
But you still go and have those 3 pieces of chocolate at night or 4 biscuits. because you just can't control the craving. That's an
You can't
emotional
resist,
and a
yeah.
mental status. That's nothing to do, that's not a physical problem.
Correct.
That is why emotional calm and inner mental peace is important. And we are at BeyondAge, we're looking at not just physical, but physical, mental, emotional, and social health.
Social health.
Yeah.
Okay. We have covered a lot today. If someone remember just one lesson from this entire conversation and actually acts on it, what would you want that lesson to be?
Okay. So I'm a liver specialist, and I would like you to go home with a message that liver sits at the center of your metabolic health, and your metabolic health decides how healthy and how long you're going to live. And the liver health is in your hands.
Yeah.
90% in your hands, only 10% is in genes.
Genes.
So if you sleep well, if you eat well, if you exercise well, and you make some arrangement in your life to be mentally calm and emotionally kind of stable and relaxed, you will actually live a healthier and a longer life.
Okay. Before we wrap up, is there anything important that you feel we didn't touch upon but everyone should know? Do you want to talk about something?
For the exercise enthusiasts, including yourself,
Yeah. I'm a marathon runner. I work out every day.
The single
Yeah.
most important measure
Yeah.
of how well you're doing in life in terms of fitness and both mainly physically but also mentally is something called VO2 max.
VO2 max, yeah.
What is VO2 max? VO2 max is like the capacity of your engine. That's what it is. So VO2 max is the maximum oxygen that a person can utilize to perform physical work.
Activities, yeah. Correct.
Right? It's measured in liters per kg per minute. And in a very large study of more than 100,000 subjects, it was found that people at the top 25 percentile of VO2 max had 4 times less chances of dying at the same age than the bottom 25 percentiles. Such a lot of difference. It's more important. So that differential was more important in that study than between smokers and non-smokers. So VO2 max is more important than like a good VO2 max versus a poor one. Bigger differential compared to smoking and non-smoking. And you know how bad smoking is.
Yeah. How come someone have good VO2 max?
So VO2 max is something that has to be slowly built up, right? And it can be done in simple ways by not having a sedentary lifestyle and doing enough cardio and aerobic exercise every day. So you should do 200 minutes a week.
200
cardio.
minutes of
Cardio
of
every
cardio.
week. It doesn't have to be tough.
Every week.
It doesn't
Okay.
have to be tough cardio. It can be walk.
Okay. Yeah.
It can be normal walk. But if you put in some HIIT, some high intensity interval
workout,
training,
yeah.
which means you run as fast as you can for 2 minutes and then you relax for a minute, or you do a 4 and 3.
Yeah.
If you do this 4-5 times, at least 2-3 times a week, and the rest of the time you're walking or whatever jogging you can do,
That is also
200 minutes.
That works.
You will max out your VO2 max within a year or two. This doesn't happen in a flash. It is not going to happen in weeks.
Yeah, it is
It's
going to
happen
take some
in
time.
months to a year.
Yeah.
Okay? But then that's an investment into the last 20-30 years of your life.
Great. It's interesting. Okay. Thank you so much, sir, for your time.
Okay, that was fun.
And I hope you liked the conversation.
Yeah, I loved
Thank you
it.
for coming.
Yeah,
It was a pleasure having you here.
that was good to be here. Thank you, Saurabh.
Thank you, sir.